It's my pleasure to talk to you today about the emerging role and applications of ALK-targeted therapy in early-stage localized non-small cell lung cancer. So, I'd like to begin with a couple of case presentations. The first case is a 76-year-old never smoker who presented with an incidentally detected mass in her lung. She underwent a VATS left lobectomy in November of 2018 and was found to have a T3N0M0 adenocarcinoma, which tested positive for an ALK rearrangement. So this was a tumor that was 35 millimeters in size and had no involved nodes and tested strongly positive for ALK by immunohistochemistry, and the presence of an ALK gene rearrangement was confirmed by FISH. She went on to have standard adjuvant therapy after surgery with postoperative adjuvant chemotherapy with cisplatin and pemetrexed for 4 cycles. A few months after completion of her adjuvant treatment, restaging scans showed the presence of bone metastases consistent with recurrent disease. She went on to commence treatment with alectinib, the ALK-Targeted inhibitor, in October of 2019. She had a complete metabolic response to treatment. She did have a dose reduction of the alectinib to 450 milligrams twice daily because of myalgias and an increased creatinine kinase. And she remains well with no evidence of disease on scans. Then I'd like to move on to a second case who also presented with early stage ALK-positive non-small cell lung cancer. This patient is a 74-year-old former smoker with a 20-pack-year history of smoking, who I saw after having surgery for a stage T1N2 M0 adenocarcinoma, which tested positive for an ALK rearrangement. He underwent a VATS right lower lobectomy and mediastinal lymph node dissection. And this showed a tumor which was 18 millimeters in size, but had multiple involved mediastinal lymph nodes, which were not suspected suspected preoperatively. And this is an important finding, as this is something that we noted in the ALENA study, that patients with early stage ALK-positive lung cancer are often positive for N2 disease. This patient was enrolled on the ALENA adjuvant trial, which we'll discuss shortly. He was randomized to the alectinib arm and commenced treatment in February of 2020 and completed 2 years of adjuvant alectinib in 2022. And he remains well to date with no evidence of recurrent disease on scans. So just to recap about ALK rearrangements in lung cancer, these are present in about 3 to 5% of non-small cell lung cancers. And it's important to test patients regardless of smoking history. And guidelines recommend testing all newly diagnosed patients with non-squamous non-small cell lung cancer and selected squamous cell carcinoma. But as you'll hear, there's now a case for testing early stage disease for ALK rearrangements as well. So we know that oncogene drivers are present in more than half of all non-small cell lung cancers, and they've really changed the treatment paradigm in advanced disease, as you can see from the ESMO guidelines here, where there are at least 10 different oncogenic drivers that we have approved targeted therapies for. But the question is, can they improve outcomes in early stage disease? And in the context of ALK gene rearrangements, we now have evidence that this is the case from the ALENA phase 3 trial. So the ALENA trial is an ongoing global phase 3 study in patients who had resected stage 1B to 3A ALK-positive non-small cell lung cancer, were randomized 1-to-1 to treatment with either standard of care treatment, which was 4 cycles of adjuvant platinum-based chemotherapy, or to treatment with 2 years of adjuvant alectinib, and were followed up after the adjuvant treatment. The primary endpoint of the study was disease-free survival by investigator assessment, and this was tested hierarchically, firstly in stage 2 to 3A patients, and then in the entire or intent-to-treat population. Other important endpoints for the study were CNS disease-free survival, overall survival, and safety.
I was just kind of curious, in the original thinking when the Alina trial was being put together, what were the discussions that went on in terms of what to do about the chemo? Because it was very different than the Adora trial.
Yeah, absolutely. So as you say, in Adora, the randomization was after chemotherapy, and the Adora trial had 3 years rather than of osimertinib, and Alina had 2 years. So there was a lot of discussion about whether the randomization should be after chemotherapy. But the feeling was that in advanced disease, the impact of the adjuvant targeted therapy was so much stronger than chemotherapy. And the decision was made, and it wasn't a straightforward decision. There were there were strong arguments either way that it really test a chemo-free option for adjuvant therapy. But I think, as you point out, because of the design of the study, the role of chemotherapy remains a question for debate, and we can I think that would be a really good discussion to bring up.
Please continue.
So if we look at the patient characteristics, the characteristics were generally even across the arms, although I do note that there were slightly more women and non-smokers in the alectinib arm. What's interesting is if we look at the surgical characteristics of the patients, about half of patients had N2 disease. And this was N2 disease that was not suspected prior to surgery. And I think does tell us that there's something different about the biology of early stage ALK-driven lung cancer compared with wild type non-small cell lung cancer. So this slide shows the primary endpoint of the study, which was strongly positive. So adjuvant alectinib improved disease-free survival compared to chemotherapy with a disease-free survival hazard ratio of 0.24. So the median disease-free survival with chemotherapy was 44 months, but not reached with adjuvant alectinib. And the landmark disease-free survivals are shown here with a 3-year landmark disease-free survival of 88% compared to 53%. And shown here is the disease-free survival for the intent to treat population, the entire study population. Very similar disease-free hazard ratio of 0.24, with a median disease-free survival of 41.3 months in the chemotherapy arm, but median not reached for alectinib. And the landmark disease-free survivals were 88% and 54% respectively. Importantly, at the data cutoff date, there were only 6 overall survival events. So overall survival data are immature, and we will need additional follow-up to look at overall survival in this study. Looking across subgroups, we saw benefit across all the predefined clinical subgroups. And looking a bit more closely at stage, we can see a pretty even effect across the stage groups. And looking at this a bit more closely, now this is stage according to version 7 of the staging manual. We see consistent benefit by hazard ratio across stage 1B, 2, and 3A, with very similar hazard ratios. There were obviously smaller numbers in the stage 1B group, accounting for the wider confidence intervals. Now, of course, the staging system has been updated for lung cancer with the 8th edition. So if we look at the new staging groups, which are largely stage 2 and 3A, again, we see pretty consistent benefit across these stage groups. And also looking by nodal status, we see consistent benefit in the N0, N1, and N2 population. Now, an important endpoint in adjuvant studies with targeted therapy or in the oncogene-driven lung cancers is CNS disease-free survival. We know in advanced ALK-positive lung cancer, there is a propensity for brain metastases. So CNS disease-free survival is an important thing for us to follow up. And we see a benefit in favor of alectinib here with a CNS disease-free survival hazard ratio of 0.22, with only 4 recurrence events in the brain compared in the alectinib arm compared to 14 in the chemotherapy arm. And this is very similar to what was reported in the ADAURA study. Now, looking a bit further at the patterns of failure or the sites of recurrent disease, we can see many fewer recurrences in the alectinib arm compared to the chemotherapy arm. We talked about the effect in the brain previously, but we see an effect in reducing both local and distant sites with reduction in metastases at multiple other sites, including bone with alectinib. Now, an important question in adjuvant studies is what happens to patients after recurrence. And this table summarizes post-recurrent subsequent therapy. And as we can see, there are more recurrences in the chemotherapy arm. And of the patients that had recurrent disease, 3/4 or 76% received a subsequent ALK-tyrosine kinase inhibitor, of which alectinib was the most frequently received ALK-TKI. Of the ones that didn't, I note that many of them received subsequent radiotherapy or surgery. In terms of adverse events seen with alectinib, the safety profile was pretty consistent with what we've learned about alectinib in the metastatic setting. So the most commonly seen adverse events were things like constipation, myalgia, and asymptomatic elevations of creatinine kinase or liver function tests. And with chemotherapy, nausea, vomiting, and myelosuppression were the most common adverse events. Only 5% of patients had to stop adjuvant alectinib treatment due to adverse events. Another important consideration is whether the 2 years of adjuvant treatment impacts health-related quality of life. So we looked at this with patient questionnaires addressing 2 components, a mental component as well as a physical component. And the results are summarized here in these 2 plots. So so just looking at the plots, the sort of 50% level is like a baseline, and we see a dip with chemotherapy that occurs immediately. But then after the 12 weeks of adjuvant chemotherapy, both the mental and the physical parameters return to baseline. And with alectinib, even though the duration of therapy was 2 years, we see that there is a similar early dip, but it returns to baseline actually before the chemotherapy. And despite the continued, the long duration of therapy, the improvement in health-related quality of life is maintained, or rather the return to baseline is maintained.
You know, a lot of times for me, it's hard to read in quality of life studies and see numbers and stuff. But let me ask you, in your personal experience, or kind of, and even bringing in trial data, roughly what fraction of people cruise through the 2 years? Like it's taking an aspirin, they don't even know it. What fraction require dose reduction or interruption, and what fraction are kind of in between having significant problems that they can deal with?
Yeah, so I might to answer that. I think we've got some numbers here. So in the alectinib arm, about a quarter of patients required dose reduction, and these are for side effects like myalgia, elevations in CK or LFTs. But only 5% needed to stop treatment because of toxicity. Um, so my sense is probably, and sort of reflected by the numbers, about three-quarters of patients do sort of sail through. An interesting, I guess, personal observation was when we got to the end of the 2 years, I did ask patients, there was another trial where the treatment was continued longer. If you had the option of continuing, would you continue? And all my patients on alectinib were happy to continue, which was
Huh.
interesting. I didn't necessarily expect that. So I guess there is a little bit of a selection bias. If you get to 2 years without problems, you're probably going to be okay for another year. But it was an interesting observation.
That's interesting because, in general, I've been kind of wondering as we see more and more longer term targeted maintenance things, et cetera, like how that really goes. For example, I know it seems kind of crazy to think this, but how would you compare trying to get somebody through a year of alectinib in the adjuvant setting to osimertinib?
Yeah, yeah, interesting one. I think it's probably a little bit easier. I think with the osimertinib, things like the mild rash, the diarrhea are probably a little bit more common, and sort of these patients who potentially don't have disease probably get bothered by it more than patients who do have disease and can see their scans improving and are happy to soldier on through it. Um, but then there are these patients that get things like edema and muscle aches and do struggle through it. So absolutely, I don't think we should minimize the the impact of these targeted therapies, even though they are sort of better than chemotherapy. They're not without without consequences for patients. And I think there's a nice slide that Jill Feldman has about the impact of ongoing grade 1, 2 toxicities on patients, which really do impact quality of life.
All right, please continue.
So just to summarize the key findings of the ALINA study, 2 years of adjuvant alectinib resulted in significant improvements in disease-free survival compared to chemotherapy with a hazard ratio of 0.24. An improvement in CNS disease-free survival is also seen with a hazard ratio of 0.22. We do need more follow-up to see if alectinib improves overall survival. And this trial establishes the importance of testing not just advanced disease, but also early stage tumors for ALK rearrangements. And this selection is important not just in terms of selecting who should get adjuvant alectinib, but we know these patients don't tend to benefit from immunotherapy. So in terms of selecting patients for neoadjuvant approaches, I think it's critical that we test for EGFR and now ALK as well. So in terms of remaining questions following the ALINA study, I think there are several areas of uncertainty. I think key ones are what's the optimal duration of alectinib therapy. We used 2 years of treatment in the ALINA study. 3 years was used in the ADAURA study with osimertinib. And there may be a role for personalizing duration of therapy. Another important question is whether chemotherapy adds any benefit to the alectinib. This was not directly addressed in the ALINA study. There are also questions about the potential role of neoadjuvant therapy. As well, there are also questions about patient selection for treatment and what to do after relapse. So what are the other key studies of ALK-TKIs in early stage disease? Well, there's several studies that are looking at this with perioperative alectinib given both before and after surgery, as well as alectinib in a locally advanced disease after chemoradiation. We don't have a lot of data from these studies, but we do have some early data from a neoadjuvant study called Nautica-1, where patients were given 8 weeks of neoadjuvant alectinib prior to surgery. And we only have data from a small cohort of 9 patients. And of this cohort, 6 of the 9 patients had major pathological responses, and 3 patients had complete pathological responses. And I think this is an interesting signal, and we need more follow-up to see whether this holds out with larger numbers. And this may be a little bit different to osimertinib, where we see very low rates of complete pathological response. So in summary, the ALINA trial has established a role for adjuvant targeted therapy with alectinib for resected ALK-rearranged early-stage non-small cell lung cancer. We need to test all patients with early-stage resectable non-small cell lung cancer for EGFR mutations and now ALK gene fusions, and really ideally other actionable oncogenes, and to discuss management of these patients in a multidisciplinary meeting. There do remain many uncertainties, the key ones of which are the optimal duration of therapy, the role of chemotherapy, and the place for neoadjuvant therapy. And thank you very much for your attention.